be today we'll be discussing youth living with HIV and the challenges they face when transitioning from pediatric care to adult care. This is a critical topic as transition is not simply just an event at 18, but it's a complex process with lifelong impacts. Next slide. Okay, so people who have acquired HIV perinatally or in childhood, typically under the age of 18, experience pediatric HIV care and then transition to adult care. A common assumption is that young people are not considered as long-term survivors, as most people assume that they acquired HIV as adults. This often excludes them from critical conversations and support. Growing up with HIV comes with its own trauma, stigma, and systematic neglects. For these youth, here are some realities that they face. So many lost one or both of their parents to AIDS without fully understanding what was happening. Some have learning or developmental disabilities due to like early HIV infection. Many grew up in low income or households far from their healthcare services. As children, they were given bitter medications or large pills with no explanation, and some experienced side effects. They were not told about their HIV status until late childhood or adolescence, which makes sense because they are not able to properly understand their diagnosis. However, it still leads to fear, confusion, and mistrust. Another thing is they faced stigma in school, like health classes, the media, and their peers, making them feel unworthy or unsafe. Medication adherence is a constant emotional barrier that reinforces their diagnosis daily. Many avoided sleepovers, trips, or public medication use to prevent from being outed. Dating, relationships, and disclosure are filled with anxiety, rejection, and risk of exposure. Living with a condition that affects your sexual identity and relationships is difficult, especially when you consider their age range. It's a time of exploration, and this is just another burden for them. They have internalized stigma because, especially after learning about HIV criminalizations and laws that disproportionately harm them. And some have remained in abusive relationships out of fear of their status being disclosed against their will. So there were so many other things that I can go on and on and on, but this is just from the slides, but also my experience with you working with youth. Next slide. So transitioning from pediatric to adult care is not just about aging out of the system. It's about preparing young people for a shift in how care is provided. Many who acquired HIV in childhood have known only pediatric teams who have supported them since birth. Moving to adult care can feel overwhelming and isolating. The system often treats the system often treats transition as a box to check off rather than going through the process that requires ongoing support. It also prepares young people for a shift to and how care is provided. Many who acquired HIV in childhood have known. Sorry, I'm repeating myself. Next slide. Preparing a youth with a chronic health condition like HIV is to move from pediatric to adult care is not just about transitioning from their medical records. It's about ensuring that they have the knowledge, the skills, and the confidence to navigate a more independent healthcare system. Without proper preparation, young people may feel abandoned or struggle with expectations faced on them or put on them when they're in adult care. Next slide. So, like I said, transition is not just medical, it's deeply emotional. Many of the youth who transition to adult care feel a sense of loss or trust, loss of trust from providers, having that familiar environment and support system. Some struggle to manage medication on their own or scheduling appointments or communicating effectively with their new healthcare providers. A successful transition must address both the practical and the psychological challenges young people face. Next slide. Okay. Sorry. Okay. So one of the biggest shifts in transition, sorry. I think I messed up the slide order. So next slide. Okay, perfect. One of the biggest shifts in transition is going from family-focused, multidisciplinary pediatric system, which is has things like a social worker, mental health clinician, their doctor, nurses, to where autonomy is expected. So this can be extremely difficult for young people who have spent their whole lives with a supportive team. For those who acquired it in perinatally, this change can feel like abandonment, especially if they've grown up with trauma or loss. So a transition that fails to acknowledge these needs increase the risk of disengagement in care. So next slide. So we need to understand that we need to be honest and understand that the system failures that these individuals face. Healthcare focuses on their transition to adult care, but ignores their long-term struggles that impacts their health. Instead of recognizing structural barriers, the system blames them for disengaging, labeling them as lost to follow-up or not caring about their health. In reality, they are overwhelmed with survival. These individuals face. So healthcare focuses on the transition, but they just ignore the long-term struggles and the impact. Instead of addressing these structural failures, these individuals, So many of them experience difficulties accessing mental health care, financial supports, and stable housing. The burden of navigating the healthcare system that are not built for their unique needs causes them to fall out of care. Without structural change, the individuals will continue to be left behind. Next slide. Okay, so the Canadian Pediatric Society has a study called A Call for Action, Recommendations to Improve Transition to Adult Care for Youth with Complex Healthcare Needs. Next slide. So they break it down into four sections. The first one being start transition planning early. So this means starting as early as can be. Some people start around 14. And it's just like bringing up like, okay, how can we make you more independent and all of that stuff. So really just working with the team and the parents to prepare their youth well in advance before they have to go to adult care. Creating individual transition plans. So what works for one youth will not work for another. So just being able to the team work together to make the transition smooth for them. Number 3 is to provide support before transition. So like I said, it's about making sure that they have what they need before they even go. And then number 4 is to provide ongoing support after transition. This is a really difficult one that I think we struggle with as a community, is that nobody follows up with the youth once they're out the door. So I think follow up is really, really important. Okay, next slide. Okay, so healthcare must be trauma informed, recognizing the unresolved trauma and the systematic neglect they face. Support must be flexible, non judgmental, and build on trust, not punishment for missing appointments or struggling with adherence. Youth are not disengaged, they're overwhelmed, is one thing that's really important. Mental health struggles, financial instability, domestic violence, and substance use makes prioritizing healthcare difficult. When someone's going through mental health issues, it's hard for them to think about leaving the house or taking their meds. So missing appointments and struggling with adherence should not be a further barrier. Care must be trauma informed and knowledge acknowledge the systematic neglect. I'll say that 600 times, but yes. Next slide. So in the US and Europe, pediatric centers often extend care to young adults up to the age of 25, providing a bridge between pediatric and adult services. In Canada, however, most hospitals mandate transition at 18, with some exceptions like the Oak Tree Clinic in Vancouver or the SIS Clinic in Hamilton, where the physician changes eight, at 18, but the rest of the team stays the same and it's in the same location. Okay, next slide. Okay. I think okay. Give me a sec. I'm lost in the slides. I think I messed up the order. But okay. So overlapping. Why this is important is because oftentimes being able to overlap the adult care and the youth, the adult care and the pediatric care is so important because it takes away some of the issues of feeling isolated. You don't have to find or get used to a new team. And it also slowly weans people out instead of just being like 18 out. So yes. Next slide. Okay, so like I said earlier, adolescence is a very difficult time for anyone and everyone. um, and so the development transition is shown right here. So there's pre-adolescence, so that's between 10 to 13. Then there's middle adolescence, which is 14 to 16 years. And then there's late adolescence, which is 17 to 20 years. And then there's emerging adulthood, which is the 21 to 25 years. Next slide. So during the adolescent years, it's important to know that like concrete to abstract thinking go it changes, and then also a lot of things that goes on with youth is that they think more of in a black and white way, like it's a yes or a no. There's not really that much of a gray area. Difficulty generalizing rules, so they have a difficulty with sometimes they'll take things very literally. And of course, there's nonlinear growth, which is like natural regression during stress and illness. Another thing is sometimes egotistic thinking, and this is not in a bad way. It's just, if I wear this, will people feel like people will be staring at me, even though we all know that no one's going to be staring at them. That's kind of an example of the kind of like the world revolves around them. And then, of course, risk-taking behaviors. Okay, next slide.
So I think this is where I get to take over. Thanks, Asha. So yeah, this idea of adolescents being magically ready for transition at 18 is kind of baloney. It isn't supported by biology. We know that the brain in adolescence matures in specific ways, and so the limbic, oh sorry, the limbic system of the brain that's responsible for like social emotional components that tends to mature earlier in adolescence, and this is part of what we think leads to adolescence characteristics like risk taking, impulsivity, like sensation seeking. And so that it's quite normal for them to have that kind of uh, development of that part of the brain and with those consequences. And it's not all bad. Like a lot of that stuff leads to like it's very important for learning, for a formation of their identity. And then the other parts of the brain, like the prefrontal cortex, develops later. And that's the part that's responsible for cognitive controls, like making good decisions, being rational in the way you're making decisions, being organized. So that all matures later than the limbic system. And so it just tells you that their brain is coming along, but it's not actually ready for what is expected of someone in adult care. And it's known that these maturation processes continue well into the third decade in their 20s. And so I dare any of you, now some of you are in your 20s, I know, but I dare any of us to think back when we were in our teens and 20s and were we making good decisions and were our rationalization of those decisions accurate, and will we make different decisions in our 30s or 40s or 50s? And so I guarantee that we all have had that experience. And so I think we need to take that into consideration when we're thinking about medical care and health care for youth living with a very stigmatized and difficult disease like HIV, when we're making our expectations for them in terms of how they engage in healthcare. So adolescents are expected to take on tasks. They're expected to be able to manage their own condition, like plan ahead for appointments, arrange to be away from school or work, focusing on the dialogue that's happening in clinic, managing their own medications or symptoms, and solving problems when things go wrong. And all of those tasks are difficult to do when you're executive functioning. That part of your brain that's like good at all that stuff is still under development. So I think part of what Asha talked about was being mindful of that in how we provide our care in that time period leading up to entering adult care and then after they've arrived in adult care, and acknowledging that some of them just aren't ready. So I'd like to share a little bit of research into this topic that's relevant. One study that many of us took part in is called EPIC-4. It was the Early Pediatric Initiation Canada Child Cure Cohort study. And that was a multi-center study across Canada involving 9 pediatric centers where it was about HIV reservoirs. And so it was very a biologic study, but we collected a lot of interesting and helpful data in that study. And one of the things we looked at was neurodevelopment and mental health. So in terms of neurodevelopmental diagnoses, we found that in the EPIC-4 cohort, which included over 90% of children and youth living with HIV in Canada who had gotten it in childhood or perinatally, a quarter of them had a neurodevelopmental diagnosis. That included language delays, both expressive language and receptive language, motor delays, global developmental delays, and HIV encephalopathy, which is like damage to the brain that can happen when infection happens in the womb. And amongst kids who had head imaging, so we used to do head imaging like CTs or MRIs of the brain routinely, not all kids, and we stopped doing that in more recent years, but 35% of the youth in this study had head imaging, which means they probably had it for a reason. And amongst those who had head imaging, 70% of them had abnormalities related to HIV. And that works out to a quarter overall of children in this study who had some abnormalities in their brain related to HIV. So that's very worth noting. In addition, 16% of them had some form of learning disability, including dyslexia, auditory processing disorders, visual processing disorders, or most of them it was unspecified learning disability, but it just tells you that they have, many of them have learning problems. And 13% of them had failed at least one grade in school. Um, and so again, that's worth noting. And then we also looked at mental health diagnoses in the EPIC 4 cohort. And again, almost 30% had some mental health diagnosis, including things like ADHD, depression, anxiety, and post-traumatic stress disorder. And so I think this is very important in thinking about when considering what the needs are of youth as they enter adult care. It's not quite the same as adults who acquire HIV in adulthood and teenage years or adulthood entering adult care, in that they haven't had the impact of HIV on their brain their whole life. And so these rates that we found in this study of neurodevelopmental diagnoses and mental health diagnoses are suggestive of a higher burden in these kids than in the general pediatric population in Canada. Much higher rate of learning disability, of ADHD and anxiety, although similar rates of depression and post-traumatic stress disorder to other studies. But I think it's really important to note that this wasn't a study that evaluated everybody for learning disabilities or mental health diagnoses. This was just what was picked up through routine care. So I think what we know is that if people are all systematically screened, we find a lot more than what we would otherwise pick up passively. Like someone would have to complain of like having poor attention or complain of having depressive symptoms to get diagnosed, rather than these being things that are routinely screened for. And I would advocate that we should be doing routine screening for these problems because they have a high impact on people's lives, and it might change the way we provide care to them. Another study I wanted to mention is from the CPHSP, the Canadian Perinatal HIV Surveillance Project. That's where we track women during their pregnancies and the outcomes of their children. And so that's mostly to look at children that are HIV exposed but not infected, but we also track in that study children with HIV. And so over the years 1990 to 2023, we had about 800 children with perinatal HIV in Canada. 200 were less than 18 years at the time of this study, so they were still in pediatric care, whereas almost 500 of them had already transitioned to adult care, or were presumed to have transitioned to adult care because they were over 18. I think notably 113 of them had died while in pediatric care, 90% due to AIDS-related conditions. And so that probably relates to the pre-heart era, like in the 90s. But still very, very sad. And 10% of them had non-AIDS related diagnoses that led to their deaths. It's important to note, though, in terms of positives, that there are no pediatric deaths amongst children with perinatal HIV in Canada since 2005 while they are in pediatric care. That does not apply to after they've reached adulthood, and I'll come to that. These are the demographics in terms of the transitioned cohort, the ones that were older, like who are over 18 already, versus the current ones who are under 18. And just worth noting that there have been trend differences in the race ethnicity of this group. Still, significant proportion are African Caribbean Black, so 65% in the older group, down to 59% in the younger group, and an increase in the indigenous children proportion from 6.6% in the older cohort to almost 17% in the current cohort, and then unknown is about 10% overall. So we don't know that these numbers could be different or higher than that. So really impacting a specific ethnocultural proportion of the population. And this is more in keeping with the women living with HIV trends in Canada rather than the adult male trends, which tend to be more gay white men. And then in terms of child birthplace, but 50% were born abroad in the older cohort and 61% born abroad in the current cohort. And then 40% of the current cohort are in Ontario. So that's relevant to us who are working in Ontario. Again, I mentioned that there have been no deaths since 2005, but you can see that the majority of deaths that did happen were in that 90s time period when before we had effective treatment. And then of the ones who are transitioned, like 30% of them are age 26 to 30 already. And so what is happening to that cohort of older transitioned survivors? And are their needs being met? So we don't really know what their needs are because unfortunately, when they go into adult care, they often get mixed in with the crowd and no one actually remembers like, oh, this isn't someone who acquired HIV at age 21 and now they're 25. This is someone who's been living with HIV for 25 years. And what is that experience as a long-term survivor like, and how is it different, and how might that impact how they need to receive care or support? And then half of the current pediatric cohort, of those 200 kids who are currently in pediatric care, half of them will transition in the next 5 years. So again, the numbers are going to continue to increase, which is good. It means that perinatally infected youth are surviving into adulthood, but that also means that they are becoming a larger proportion of the current adult cohort, and are their needs being met? The last bit of research I'll share with you is we did a review of outcomes for adolescents here in Eastern Ontario. So from our clinic, moving to the adult clinic at the Ottawa Hospital, resident Julia Hunter-Shula had done that work with myself and Jonathan Angel. So we looked at a group of 21 kids youth who had transitioned from pediatric to adult care, and we compared them to a group of 32 youth who had entered HIV care directly at age 18 to 20. And so we thought that was a good comparator group, and then like when you have a youth coming into adult care, are they different if they've been living with HIV for a long time versus being recently diagnosed? So you can see that the majority of the comparator group are male, and that reflects probably more amongst the men who have sex with men group. And then 50% of them were born in Canada. 20 age 20 years was the median age of entering adult care. And then we followed them, we looked at them over time because that was a group that like ranged from like people who had recently transitioned in the last 1 to 2 years up to people who had transitioned like 15, 20 years ago. And so what did we learn? We learned that both groups have problems, which is in keeping with what I talked about already, and with respect to like the brain not being totally ready for the demands of adult care until they're a bit older. So in terms of successful engagement within the first year, we saw that 90% of the transition group and 100% of the comparator group were successfully transitioned in that they had at least their blood work done in that first year. And then the 3-year engagement was similar at about 85% versus 81%. That means remaining in care, but not like pretty far from 100%, so not ideal. In terms of sexually transmitted infections, the majority of the comparator group had STIs diagnosed while they were in adult care versus 10% in the perinatally infected group. But very high rates of mental health conditions in both groups, 57% in the comparator group versus 45% in the transitioned group. And then lastly, in terms of self-reported adherence, which I think is really important to think about, only 19% of the transition group had good or excellent adherence versus 56% of the comparator group. So clearly, and I think we could imagine some reasons for that, in that if some people have been dealing with HIV and having to take medications for 20 years, then they can get sick of that. And then the proportion of time with viral load suppression was 83% in the comparator group versus 58% in the transition group. So again, reflecting less HIV control over time. And so what did we learn from this overall is that locally, youth living with HIV who transitioned to from pediatric to adult care had less engagement in the first year and in the subsequent years compared to those entering adult care directly, less time virally suppressed, and poor treatment, self-reported treatment adherence. And so I think this is really a reality check. It should be a reality check for all of us who are working with this group. And that like this was a small, like the last part was a small group here in Ottawa, but overall in Ontario over the last 15 years, there have been multiple cases of perinatally infected young adults who have died or have been admitted to hospital with AIDS or cancers related to HIV. I personally have like 5 or 6 youth that I know who have died because they were not able to take their medications and have control of their HIV. And that isn't just about medications, right? That's about the healthcare system and how did we fail them that was allowed to happen. And I think it's easy to forget when you see youth in adult care who appear young and healthy on the outside. It's easy to forget that they are long-term survivors who've been living with HIV their whole lives, compared to like adults who are in their 60s or 70s who've been living with HIV in the same time frame. So it's easy to forget that they have greater needs. And I think youth moving into adult care need extra support, especially peer support. And we need to devote more effort and resources to ensuring that peer support is made available to them. So we know from the literature outside of Canada and inside Canada that transition teens have increased rates of ARV discontinuation and resistance. This is a study from Montreal that showed 2/3 of youth moving from pediatric to adult care were failing their treatment at the time of transition, and 1/3 of them had triple class resistance, meaning they had resistance to all 3 of the main HIV drug classes. So entering adult care with a lot of problems. Uh, uh, we know that in US cohorts, up to 20% lost to follow-up after transition to adult care. And we know from the UK and the US increased rates of dying, of mortality related to HIV after moving from pediatric to adult care. So again, this is a priority group in my mind. I'm biased, but I think the data is very clear. So how do we support them to do well when they're leaving pediatric to adult care? So previously there was a Good to Go program. It was a transition preparation program at Sick Kids that many of us have adapted to use in our centers, and it basically had some work on some activities and tools that could be used to help prepare youth. One of them is a 3-sentence summary. So that's like making sure that a 15-year-old, 16-year-old is able to present themselves to a healthcare provider and effectively communicate who they are and what they need. So 3-sentence summary. Hi, my name is Sally. I'm 16 and I have asthma. I've been hospitalized twice with asthma, but not in the last 5 years. I've been taking my asthma medication since I was 3. I'm here today because I can't run. I'm wheezing. So we want youth living with HIV to be able to say that I was born with HIV and I was diagnosed with it when I was 2. I had like TB at that time, but I haven't been admitted to hospital in the last 10 years. My last CD4 count was 500, and my last viral load was undetectable. I'm here, and my medications are Trimec, and then I'm here today because I broke my arm. To prepare them, because a lot of kids are reliant on their parent or someone else to tell their story, or they're reliant on us to know them well and know what they need. And so when you're going to someone new, you need to be able to like present who you are and what you need. We also have this readiness tool, and there are other ones as well, that basically allow us to assess over time, like what are youth able to do. So this is like a list of 20 questions, and it basically lists the things that people are expected to do in adult care, and then find out how ready does that youth feel to do those things. So uh, for example, I'm in charge of preparing and taking my medications or treatments on my own. I never do this. I rarely do this. I sometimes do. I often do. I always do. Um, I can get myself to healthcare appointments. I spend time with my healthcare provider at each appointment. Um, I know the names of my medications or treatments. I know how my medications or treatments are paid for. I know what to do when I run out of medication. So these are very practical things that people are expected to be able to do when they're an adult, that they're not expected to do as a young child. And so we need to identify what are the knowledge gaps and ability gaps, and allow them to work on those things while they're still in a supportive environment in pediatric care. The problem, I have to say, is that we try to do this on a regular basis, but often youth come to the clinic with a problem. And so we have to deal with their problem, and then we don't have time to deal with their transition preparation. So sometimes it can be difficult. But at CHIO, we try to have team groups, and we cover transition topics and transition knowledge. And we also do things like go for a tour over at the adult clinic so they get to see what the new environment would look like, get to meet the nurse and one of the doctors and the pharmacist, see where the lab is and what it looks like, just so that it's not all unknowns to them. I won't go through this. This is just another checklist that was published in the literature on assessing adolescent readiness for transition. It's more meant for a low-income setting, but it has the same types of knowledge assessments and spheres of knowledge. And then this is a really nice publication from a few years ago on transition needs, and trying to let adult environments know what is a transition friendly environment, and how can we provide that for youth. So including things like access to mental health services that are easy and you know exactly how to access them. Having a formal transition policy on how you're supposed to prepare and then receive patients when they're entering adult care. I won't go through that. So like I said, peer support, I think, is really important, meaning they're not living alone with this. The majority of youth in our clinic don't talk to their other friends about HIV. And so often every 3 months that they come to see us is the only time they talk about HIV. And so I think it's important that they're not just talking to like stale adults like me, but they're able to talk to their peers, so that they know that they're not alone with this. They know, like, oh my God, that Triamec is so big. I can't believe we have to swallow this giant pill. Or like, how do you deal with dating, and when do you think about telling your partner about HIV? Like, these are things that, like, learning from peers or feeling like it's a shared burden is actually really helpful. So we do that at CHIO with our teen groups, and this is like an outing. It's not just about knowledge, but also about bonding and having fun together, so that you're going to remain friends into the future. Camp Mandala is a camp put on by the Teresa Group. There's another great one in BC called Camp Mumba. So these again are camps where people can build peer relationships and build their own peer support networks. And then PYO is another good example of a youth group out of ACT that helps people connect. And I know Asha has her own youth group that she started on her own, and kudos to her for that initiative. And I think it is so important. Okay, I'm going to transition back to Asha. Oh, you're on mute though, girl.
Sorry. So I'm excited to talk about this one because it's the HYPE Youth Summit. So that's the HIV positive youth peer engagement. That's what HYPE stands for. And it started off as a response for transitioning, but today it supports all youth from the ages of 16 to 29 who are living with HIV, and it's Ontario-wide. I am aware that most of the examples we gave were Ontario. So if you live in another province and you know of other youth groups, please put it in the chat. Let us know. We'd love to hear and see what else is out there. Yeah, next slide. So the transition accord was created as a response to the Ontario AIDS strategies adaptation of the HIV prevention / treatment cascade to attempt to inform better engagement of youth transitioning from adult care to transitioning from pediatrics to adult care. So the AIDS Committee of Durham and OHTN invited 12 youth living with HIV from across Ontario to participate in the creation of the Transition Accord. Next slide. So these are my favorite slides, the next couple of slides, and I'll try to go as quickly as possible because I know we're running out of time. So one of the arching themes that that the youth brought up in this accord was do not treat me like a number. I'm a human being. I love that. And you can see the different writings from the chart. Okay, next slide. Another one was being treated like a long-term survivor. Like I said earlier, people forget that they have been living with this disease for 25, 30 years. So yeah, next slide. So the next one was, we need a community of youth while we're in adult care. So this is really, really important. I think one of the reasons why one of the ways that people stay in care is knowing that my friends and keeping peer support. So yeah, next slide. Talk to me the way I understand. So I'm 18, not 35. I love this one. It's funny, but it's true. Having culturally responsive, but also easy to understand language is so important. Next slide. And then we want to have reminders of appointments. So yeah, I think that's a good point. I loved all of the some of us would love to be 35 again. But yeah, so yeah, next slide. Okay, I'm so excited about this slide. So harnessing opportunities for progress through lived experience, HOPE research program is a research program that I'm hoping to launch. And its objectives are to amplify the voices of those who acquired HIV in childhood, to prioritize research, advocacy, and policy change to address lifelong struggles. So this work needs to be funded and needs collaboration, not competition. These youth have been ignored for so long, and it's important that not only their experiences, but also they get the supports that they very much need. And then, so one of the other things that HOPE is hoping to do, pun intended, is to ensure that their needs are at the forefront of healthcare policies, mental health supports, and long-term planning. So, like I said, funding should not be optional. It's essential. This is not about charity. It's justice. Silence and inaction must end. So HOPE needs investment, not barriers. And the reason why I started this thing, or started this research, well, I want to start this research project, was solely because of the ACB, African Caribbean Black Youth Group, that I started with one of my colleagues, Salam Hugos. And from there, I saw that there was a lot of barriers to supports. We work tirelessly, and the group has grown to 55 members just in the Greater Toronto area. And we took on a lot of a lot of case management work, healthcare advocacy, fighting to get youth family doctors, taking them to appointments, anything and everything. And we just really, really need, we really need support. And I really want to bring, this is why hope is so important, is so that I can bring these things up and we can look into it and we can get solutions because it needs to happen.